Welcome everyone. This is Miss Sheridan from GNTC Floyd County Campus, and I'm going to be doing your lecture today on Chapter 5, Documentation for Fundamentals class. Documentation is the act of charting or making written notation of all the things that are pertinent to each patient for whom you provide care. It is a written account of patient care that is going to be maintained in a chart, and it will serve as a permanent medical record. So it serves as evidence of what transpired throughout the shift while treating a specific condition or during an event requiring medical care. When you document or chart, you're going to record a patient's progress in treatment during an illness, outpatient procedure, office visit, home health visit, or hospitalization. It is one of the most important tasks that you're going to perform on a daily basis. So any written account of patient care will be maintained in the chart or an electronic health record, EHR, to serve as a permanent medical record. Written documentation serves at least 4 purposes: to communicate pertinent data that all healthcare team members need in order to provide continuity of care. And when we speak about continuity of care, we are talking about that sound, timely, very smooth, unfragmented, seamless transition from patient care of one nurse to another. So like shift change, for example, and it's also utilized during transfer of the client to another health facility. Another purpose of documentation is to provide a permanent record of medical diagnoses, nursing diagnoses, the plan of care, the care that was provided, and the patient's response to that care. Documentation also helps serve as a record of accountability for quality assurance purposes, for accreditation and reimbursement purposes. So it motivates continual internal assessment and evaluation of care that is delivered so that they can pick out the weak points to improve upon. Remember, the chart also serves as the legal record for both the patient and the healthcare provider. All staff members document all of the care they provide. For patient care to be effective, it must be delivered and evaluated continuously, systematically, and smoothly from one hour to the next, including, through staffing changes between shifts. So this cannot be accomplished without communication of the patient's current condition, changes that have transpired, care that has been delivered and its effectiveness, meds that have been administered and their effectiveness, as well as the care to be delivered in the oncoming hours. Confidentiality of documentation is of utmost importance. HIPAA requires that medical data be maintained in a confidential manner at all times. This applies to the patient's chart, results of diagnostic procedures and consults, as well as any notes you might have written down regarding the patient's health status. Confidentiality is violated when personal information is provided to another person without a patient's permission or knowledge. This can lead to litigation, and it can cause a person unnecessarily and unwarranted hardship. For example, take 2 nurses standing in an elevator, and they are discussing with each other a patient's condition with other people present in the elevator. That would be considered a breach of patient confidentiality. They are breaking HIPAA there. Remember that you cannot confirm that an individual is a patient in your facility without specific permission from that patient. All medical records must be protected and maintained in such manner that no unauthorized individuals have access to them. So only the healthcare providers that are directly involved in their care. You want to take special care not to leave any, patient notes or lab results, any medication records, or even just your own, report sheet lying around where anybody can see it. Most nurse stations have a paper shredder, so it'll aid you in help keeping records private, like shredding your report sheets when you're finished with your shift. You often hear of the phrase, not charted, not done. So that is interpreted to mean that if something is not documented, then it was not done or did not occur. Not charted, not done also requires you to chart with a clear understanding of the following: that documentation that is lacking in full detail serves to support even false claims of negligence or malpractice. Remember, lawsuits often are not filed until years after the precipitating event. So possibly long after the patient or event has been forgotten by the medical personnel who delivered care at that time. If you should ever find yourself involved in a malpractice suit brought on by one of your patients, especially one whom you do not remember, you're going to find it very comforting to discover that you were very careful to document objectively, accurately, and thoroughly. The original written or computerized medical record, even though it is about the patient, it is the property of the hospital or facility. In a physician-owned medical office, the record would be the property of the physician in that instance. So the chart or the medical record belongs to the hospital or the facility or the physician in the case of a physician-owned medical office, but all the information that is contained within that chart belongs to the patient. The patient is guaranteed by HIPAA the right to view and obtain a copy of their medical record, but the patient does not have the right to take the original chart copy itself. HIPAA ensures the patient's right not only to view and copy his or her own medical record, but also to amend his or her own health information. HIPAA requires hospitals and medical sites to disclose to each patient in writing the way the patient's health data will be used, and ask the patient to specify who can obtain that patient's personal health information. So hospitals have become more careful regarding who can view the chart. Most require the patient sign a document who they want to be able to view the medical record or obtain verbal reports about their condition or their tests, their surgery or diagnostic test reports. So you're responsible to find out what your facility's policy is regarding this issue. Any handwritten notes or copies of anything that contains confidential patient information needs to be shredded once their purpose has been fulfilled. And also, you need to be careful when you are faxing documents. To maintain confidentiality, it is best just before you fax the medical record to telephone the intended recipient and inform them of the impending confidential fax. That way it's not just laying there on the fax machine for anyone to grab and read. It's just a safety measure. So that just ensures that their confidentiality is maintained in the best manner. The report form. It's commonly known as brain sheets or pocket brains by nurses. Some facilities have a standardized report form that they want nurses to document their report on, but other facilities leave it up to the preferences of the nurse. The report form includes things like the room number, patient name, age, gender, and their physician, date of admission and diagnoses, how often they get their vital signs checked, their activity orders, their diet, any diagnostic tests to be done, or any pertinent test results that nurse needs to be aware of, any personal care that may be needed, like a bed bath that day, or maybe they need their wound dressing changed, all nursing care to be delivered, and it always has some room for some additional note-taking. You're going to need room to make notes throughout the shift as things occur. So a lot of nurses refer to them as their pocket brains. Few nurses are able to accurately remember all the necessary details that should be documented and reported to the oncoming shift. Without some form of pocket brains, it is best to write things down. Do not rely on your memory. Some nurses actually create their own self-designed report sheet format that works best for them, and that's awesome. So if you make your own, just figure out what works best for you and be certain to use the same order or format for each set of patient data and draw blank lines or check boxes for making each task completed. So making notes on your brain sheet throughout the shift is helpful as well, especially, real world stuff. We don't always get to chart right after it's done. That is preferable, but it's not always possible to chart right then and there. So the nurse could make notations on this report form or a piece of paper, and then that way they can come back at the end of the shift. No matter how busy you get, you have your notations to look back on. So no matter how busy you get, there are certain things you can do to increase the accuracy of your documentation. And one thing you can do if you can't document right after you perform the care is to write a quick note for yourself, just so when you go back and make your nurse's notes, you have all that data. And make sure to take note of the time that the care was provided as well. The ideal method to ensure that documentation is as accurate as possible is to consistently chart immediately after the care is provided, after assessment data is obtained, and after any event or occurrence that has the potential to affect the patient. So that is the ideal scenario there. That increases the accuracy of your documentation. It's not always a reality, like I said in the previous slide. So one thing you can do is write yourself a quick note. Take note of the times as well, because those things can be hard to remember at the end of your shift when so much has went on in your shift. You will be so thankful that you took good notes and you have that to fall back on and have good nurses' notes. Incident reports are also known as variance reports, so they are used to document out of the ordinary things that happen in a facility. So when completing an incident or variance report, it's important to be objective. You only want to document what you as the nurse were able to detect with your senses, what you saw, heard, smelled, or were able to feel with your hands. Avoid interpreting what you saw or heard, such as heard the patient fall from the chair to the floor. Keep it completely objective, such as, this is a better example, heard loud crashing sound. Rather than write that the patient fell out of bed, Document only objective data like found patient lying face down on the floor beside the bed. That's what the nurse observed. Or the patient reports he fell out of bed while trying to reach his telephone. You never want to document assumptions or drawn conclusions. So incident forms not only include the incident that occurred, but it also includes the action that was taken and any care that was provided after the occurrence. Like if your patient fell, for example, and you went and got a set of vital signs on him or her, you did some first aid care, you did a quick focused assessment for any injuries, and then you called the doctor. You're going to take note of that physician on the incident report as well as any orders that him or her might have given you. And it's your responsibility as the nurse, if you feel like something is important, to relay that information to the doctor. Like if you think the patient has a broken hip or something, like maybe one leg is slightly shorter than the other, or it's rotated out, and you're concerned about it, you need to speak up for that patient and ask for things that you need, like an x-ray. Even if the physician may say no at first, you just speak up for the patient and say, you're the one looking at them right now, and you feel like they need that x-ray. And then if they still don't order it, you're just going to write no new orders received. I, as the nurse, suggested that we got this x-ray and the doctor did not give me any new orders. So you're covering your booty. Incident reports also include a list of any witnesses who observed the occurrence. Like, for example, was there a family member in the room, or maybe a CNA or something? You would note that on the form. You would note the physician you notified and what orders were received. You would have to sign it as the employee involved or whoever discovered the incident, and the supervisor's signature. These incident reports are kept separate from the patient records, and they are reviewed and analyzed by facility committees, like quality assurance committees, for the goal of improving on, like, for example, patient falls. We want to decrease our falls. So they want to prevent further occurrences of these incidents from occurring. The incident or variance report provides an accurate record of what happened for use if legal action does result. For more information about the care plan, see Chapter 4, PowerPoint and Lecture for details. These are things we want to remember when we are documenting in a patient's chart. We want to avoid taking shortcuts, even though it can be tempting at times when you were so busy. You want to make sure you are documenting everything pertinent about your patient. You don't want it to come and bite you in the butt later. You want to cover all the bases. You only want to use the appropriate abbreviations. So later in the slideshow, we will cover the unapproved abbreviations, and we will have a little chart that you can look through. You never want to chart your assumptions. You want to be as accurate and objective as possible. I like this chart a lot because it compares subjective documentation versus objective documentation, and you can really see the difference here. And the objective entries are much better, higher quality documentation. Objective is what we want. For example, subjective, it's very vague. Ate well, tolerated it well. Well, what does well mean? Define that. Well, objective, that patient ate 80% of the full liquid diet. So they told us what they were eating too. This one didn't say what type of diet it was. and they tolerated it without nausea or vomiting. Worried and nervous about impending surgery, instructed about procedure. That's our subjective entry. Objective says sitting in chair at bedside, tapping fingertips on arm of chair, bouncing left leg repeatedly. Inquired if he had any questions or concerns about surgery tomorrow. Responded by asking several questions about surgery. Sat beside him for 15-20 minutes and answered questions, marked surgical sites, explained what to expect. We went through the patient teaching brochure, encouraged to read it. States that he already understands better, doesn't feel as nervous as he did, but we will call if he has more questions. Posture is more relaxed, no longer tapping fingers or bouncing left leg. You can see that has a whole lot more details than the subjective entry. Look at this example down here. Had a good night. I actually saw that in the chart once that a night shift nurse wrote, and it was just, that's all they wrote. That was their nurse's note that night. They had a good night. That's not an objective entry. You need to get more details than that. Also, you need to be charting every 2 hours at least, depending on your facility's policy. Make sure you check up on that. How often does your facility want you to make a notation? These are your unapproved abbreviations that should not be used. So you need to familiarize yourself with these. It's your responsibility to know which abbreviations and symbols may be used in your documentation and which ones may not be used, which ones are unapproved. And that's due to the Joint Commission's National Patient Safety Goal to improve the effectiveness of communication among caregivers. So to meet this goal, Joint Commission wanted to standardize all the abbreviations, acronyms, and symbols used throughout. And that includes developing this do not use list of abbreviations, acronyms, and symbols. So just get yourself familiarized with these, the set of unapproved abbreviations. A source-oriented medical record is organized according to the source or type of data. It's using specific forms for each, and it has different sections designated by a labeled tab, which we will talk about here in just a second. These are all the different sections of a source-oriented medical record. So it contains the admission record, their advance directive, surgery and procedure consent forms, physician orders, graphic data like the vital sign flow sheet, for instance, or intake and output, care flow sheet, care plan and nurse's notes, lab results, diagnostic test results, etc., history and physical, the medication administration record, our physician progress notes, and a tab for discharge planning. So you can see it contains a lot of different tabs in this source-oriented medical record. Problem-oriented medical records differ from source-oriented in that they are organized around the patient's individual problems rather than where the data came from. So the sections of a problem-oriented medical record are the database, problem list, plan of care, and progress notes. Now we're going to get into talking about different methods of charting, and we will be discussing each of these bullet points in the following slides. Some facilities may prefer for their nurses to chart using the SOAPier method of charting. The S stands for subjective data. So that is information verbalized by the patient. So only the patient knows how he or she is feeling. And they are written in quotation marks. O for objective data. So those are data that's related to the problem. It's something that the nurse is able to, gather using their senses. A for assessment data. Assessment data refers to the problem you identify after you analyze the subjective and objective data. So it's very similar to the nursing diagnosis step. P for planning. Here we go again. It sounds like the nursing process, right? So now you're planning on how you're going to resolve that problem, coming up with some goals. I for intervention. This refers to a specific and measurable actions that you're going to take to help the patient resolve their problem or better meet their outcomes. E for evaluation. So it's identical to the evaluation step of the nursing process. So were your interventions effective or not? Did they help the problem? Did they achieve what you intended? And R for revision. So there may or may not be a necessary revision for each problem. So you have to kind of decide, do you need to tweak anything? Does the patient need more time to meet their goals? Or maybe they completed it. Maybe they met the goal with flying colors and you don't need it anymore. You could revise as in they no longer need that goal. So you just kind of have to reevaluate at the end. Pie charting is another method of documentation that might be used. It's much shorter and it documents fewer data than the SOAPier charting style in the previous slide. It only addresses the patient's problems. It's not looking at the whole picture. So PIE is also an acronym. P stands for problems, I for interventions, and E for evaluation. So in this example here that's on the slide, we have the problem, crackles heard on inspiration in the bases of right and left lungs. I, the interventions, well, what did we as a nurse do about that? Incision splinted with pillow, instructed to breathe deeply, open mouth, and cough at the end of expiration. E, evaluation, is that the lungs cleared with coughing. So that is an example of pie charting. Focus charting is focused on the patient and patient concerns, problems, and strength. Note that there is not a constructed list of specific problems like in pie charting. It reflects the steps of the nursing process as well, and it stands for data, so that's objective or subjective, A for action, which would be our interventions, what we did, and R is a response, responding to the interventions and the evaluation phase. So you can look at this example right here at the top. D for data, the bladder was distended 2 fingers above the pubis, has not urinated in 8 hours since catheter was removed. So that is the assessment data that the nurse has gathered. A for action are interventions. We assisted to the toilet, water turned on at faucet, instructed to press over bladder with hands. R response, voided 525 milliliters of clear urine. So that is an example of focus charting or DAR charting. Charting by exception is quite different from other types of charting. All activities of daily living, all vital signs, and assessment findings are charted on a checklist type flow sheet rather than written out as an individual entry. And I have an example of that on the next slide. And this is used a lot in hospitals and emergency rooms, for example. Only variances from normal, or what you would call exceptions to the rules, would be written down as entries. With charting by exception, you need to use your facility flow sheet. Like this picture I have right here, see all the check boxes? And so you would document your baseline nursing shift assessment, and you would take note of anything abnormal on this flow sheet and make a nurse's note about it. You wouldn't need to make nurse's notes over anything that is considered to be normal. You're only going to chart any exception to the rule, anything abnormal or out of the ordinary, you would make a nurse's note about. All other normal data are going to be included in your baseline nursing assessment, which is a checklist-based assessment. Narrative charting tells a descriptive and continual story of the patient's experiences during hospitalization or in the facility in chronological order from admission through all the changes in the condition to discharge. So you're writing everything down. Normal and abnormal go in the narrative charting. So it differs from charting by exception in that way. You must chart at least every 2 hours, but of course you need to follow your facility's policy. So there are a lot of advantages in that it provides a lot more details than most charting styles. It depicts a great timeline of the changing conditions of your patient. It provides excellent protection in court, but disadvantage is it's very time-consuming. The electronic health record. So a law was signed by President Barack Obama that was mandated that healthcare industry participate in the development of computerized patient records so that it could be utilized by all healthcare facilities by 2016. This EHR, or electronic health record, is defined as a record of an individual's lifetime health information, and it's easily updated, easily transferable. And the nurse's documentation in that electronic health record can significantly improve the quality of patient care. It helps reduce errors. It helps emphasize the patient's needs and problems, helps provide communication for all the healthcare staff caring for the patient. One thing you want to be careful for with these checklists that are on the electronic health record, never allow yourself to fall into the trap of using one of the words or phrases available just because you're in a hurry and you don't want to take the extra time to go to the narrative section. Usually they will have a checkbox that says other so that you can type in your own response. Never allow another individual to see or use your password, of course, to access patient records for any reason. You must remember that the nurse only has access to those records of patients for whom the nurse is caring for. A computer password does not give you permission to access the records of other patients for whom you are not providing care. Long-term care documentation. So long-term care facilities are not yet required by law to use electronic health records exclusively. Many continue to use paper charts, while some others are moving slowly towards electronic documentation. A lot of them like to use the Cardex, and this is the example on this slide here. It contains written data that is used for quick reference about each resident's care, and it lists all the care that should be provided for that specific resident. The physician's orders and the nursing orders for each resident are on the single page. It's on one page, so it can be retrieved very easily and very quickly. These are some important guidelines for documentation. You want to use blue or black ink per your book. However, in my experience, most facilities recommend using black ink only, just because blue ink does not fax or copy as well. You also want to avoid pencil and any other colored inks. You want to write neatly and legibly. You want others to be able to read your handwritten notes. Otherwise, the risk of errors increases. Sign each entry with your first initial, last name, and credentials according to facility policy. So this is talking about guidelines for paper documentation, if you were charting on paper. Include the time and date with each entry. Follow chronological order. You must make entries in a timely manner, so as soon as possible after the occurrence. That's the best policy. Be succinct, so make entries brief, concise, and to the point. So it's not necessary to use complete and grammatically correct sentences when documenting. The accepted standard is to omit unnecessary words that are not pertinent to the clarity of the entry, such as the or a. Because the chart is written about a patient, it is not necessary to use the word patient. You can leave that out. This applies equally to other patient designations, such as client or resident. So you can leave all of that out. It is understood that you are documenting about your patient, client, or resident. So it's just redundant. Use punctuation. Use a period at each end of the sentence. Avoid use of exclamation marks or question marks because they tend to imply emotion or doubt, and that can make the entry appear subjective. Remember, our ultimate goal is to chart as objectively as possible. Use continued notes. So when there's not enough room to complete our entry on a page, we have to continue on the next page. Stop writing on the last line at the point that leaves room for you to write continued. And then you're going to sign your signature and credentials. You want to keep the medical record intact. Never discard of any part of the medical record. Even if a page of your nurse's notes becomes saturated with soda you were drinking, do not discard the page after you recopy it. If part of it is so damaged that it is no longer legible, make a notation on the damaged page indicating the portion of the page that will be rewritten and make reference to the recopied page. Example, recopied to page 3. If the chart becomes too full, the secretary does what's called thinning the chart. The latest reports and notes are kept in the chart, while the older reports get thinned out and filed in medical records for safekeeping. So when using a paper chart, blank lines serve as an invitation for another to write something in the middle of your charting that could look like you wrote it. So if you do not fill the line completely, you are to draw a single straight line through the middle of the space, extended the last word to your signature. And I already noticed something with this charting here. I would draw a line right here. That's a blank space. So you draw a blank, you draw a line, and then your initial, last name, credentials. So just remember that's an invitation for somebody to chart something that could potentially look like you wrote it. You want to take care to correct mistaken entries. So this is again talking about paper charting. You are going to mark a single horizontal line through the incorrect word or phrase, and you can write mistaken entry or error and your initials just above the incorrect words. You are never to use whiteout. Whiteout is not permitted. Avoid using markers or multiple ink marks, like you don't want to scribble all over the words in an effort to completely blacken out that mistaken entry. That's going to raise suspicion regarding the entry. You also want to avoid writing over incorrect letters. Instead, just cross it out, one single horizontal line, write mistaken entry or error, and then sign your initials. And then you will go ahead and write the correct word or phrase that you were trying to write. Military time is used to decrease confusion between AM and PM hours. So it's used in our nursing documentation. After 12 noon for the PM hours, simply add 12 to the hour. A colon is no longer used for military time and the minutes remain the same. So example, for 3 p.m., we're going to add 12 to the hour to get 1500. So example, 3:50 p.m., it would be 1500. This will come as second nature to you once you get used to it. Long-term care admission documentation. So long-term care has extensive admission forms different from an acute care hospital regulated by Medicare and Medicaid. The U.S. government regulates the documentation that is required in long-term care, and those requirements may vary according to the level of care required by the resident. Minimum data set for resident assessment and care screening. So a federal law known as the Omnibus Budget Reconciliation Act mandates that an extensive assessment form called a minimum data set must be completed for each resident within 4 days of admission to the facility and then updated every 3 months. So that includes their demographics, identification and background patterns, customary routines of the patient, communication, hearing patterns. And they also document on weekly summaries, like the ability of their residents to perform activities of daily living, elimination control or habits, nutrition status, their ability to communicate, social activities, etc. And then charted daily on checklists would be like their medication administration records, their MARs, or their hygiene, documenting their meals and elimination. Home health documentation is regulated by Healthcare Financing Administration, and it is audited by Medicare and Medicaid. They also have extensive admission forms to verify the patient meets criteria to admit to home health care. Charting done with each visit that shows progress or failure to progress towards their goals. These are 5 documentation mistakes that carry increased risk of malpractice. So the first one is failure to document assessment findings. Because nurses are the only healthcare providers who provide patient care 24 hours a day, 7 days a week, it's most likely that it'll be the nurse who is first present when there's a change in the patient's condition. So failure to identify and document even what may initially appear to be a minor change in condition could put the patient in jeopardy. You are responsible for documenting not only your abnormal assessment findings, but also the actions you took to address those abnormal findings. Never depend on another individual to document your assessments or care. Be diligent to document all of your assessment findings. Take it seriously. And also never document anything that you didn't assess yourself. Failure to document medications administered. You want to follow your facility's policy for administering and documenting medications. Always record the drug name, dosage, and route of administration, the correct time of administration as soon as possible. So you want to document that medication as soon as possible after administering it. Failure to document administration of a medication carries the potential for another mistake to be made. If another nurse sees that no documentation that a medication was given, he or she may give it again, thinking this is to be the correct course of action for the patient, and also thinking that he or she is doing you a favor as well. The patient has then received an extra dose, the significance of which is affected by several factors: the type of drug that was given, the safe dose range, the patient's age, their liver and kidney function, and their response to the medication. So I've seen this happen a lot in practice, and it can be very dangerous depending on what medication it is. It could be a narcotic that if they get too much, it can suppress their respiratory function. Always call the previous nurse if the dose was not charted. Failure to document pertinent health history. That could potentially cause the physician to miss something and put the patient in danger. It could include failure to document medication and food allergies. That could lead to a severe allergic or anaphylactic reaction. Failure to document physician orders. So once the physician writes an order for any type of treatment, test, procedure, med, etc., the orders go through a process known as noting or transcribing the order. So if the doctor gives you an order over the phone and you fail to document it in the chart, you fail to put the order in, that could have really harmful consequences. It carries the potential to even be life-threatening for your patient. Documenting on the wrong chart or medication administration record. So it's very easy to accidentally document about your patient on another patient's chart. Every nurse does it at one point or another. We're all human. A lot of patients might have the same last name, called name alerts, and sometimes they even have the same first and last names, making it very difficult to differentiate between their charts and their MARs. So a nurse should never be assigned two name alerts that have the same last name, or the same first and last name for that matter. They should always have separate nurses. Always check the chart and each page of the MAR for the patient's full name, room number, physician, and identifiers before documenting in the chart or following orders located in the chart or MAR. So if you do document in the wrong chart or MAR, you would just take note of that. Like you could mark the entry as an error and sign it, and then you would go about making your entry in the correct chart. So these are our review questions at the end of the slideshow. Which type of documentation form is used to record out of the ordinary occurrences? Out of the ordinary. So that would be our incident report. What information would be included in a problem-oriented health record? Problem-oriented. So remember, they're different from source-oriented records because they're organized around the patient's individual problems rather than where the data came from. So they're focused on their problems. Remember, the problem statement is the nursing diagnosis. We're following the nursing process. So the plan of care, answer B.